going to continue the afternoon session. We're going to switch gears and we're going to do a little sports medicine. We have Dr. Papp and Dr. Ross speaking. So Dr. Papp is talking about early AI utilization by a single mid-career surgeon, MoMo and MoMo AI Pro. I don't know what those things mean, but you're going to be enlightened.
So I wanted to spice things up and maybe make it a little bit, I'm going a little bit off key here. So everybody's talking about robots and all this stuff that's right on the edge. We're talking about nerve transfers. So I thought maybe we could add a little bit of AI to this talk. So, you know, if you look at this, this is a single surgeon's initial use of AI into his practice in life. I don't have any financial disclosures. There's no conflict of interest. Again, it's a limited study. It's a single surgeon using 2 AI platforms. This is first 40 cases. So again, these are my initial impressions. There is a learning curve. There are some complications, so I do want to share this. So yeah, we'll start with MoMo AI Pro. We use version 1.04/7, whatever. It has 40 preset features. You can use text to a final product, and then you can use photo to a final product. So you can ask it what it's going to do, and it'll give it to you. So like, this is my first use of this. And just wait. Look at this. It's amazing. Totally amazing. Look how happy they are. And they're totally safe, totally safe. Wait, watch this. This is even better. He transforms. Do you see? It's a beautiful becoming. Watch this. Wait. You know, things can sometimes get really tense in the exhibit hall. I'm disappointed that my joints colleagues had to do some family stuff because they're robots. Like, why would you not use this? That being said, you know, there were some complications. I thought Dr. Rose was going to be here. I asked it to make him, I was like, make him into a Batman character, and this is what we got. And so I just want to share my experience with AI. There are pros. You know, it's safe. It cuts you off at 15 videos per week, so you can't just throw money into it, which is good and bad, because I could have sat there for hours. The reason I got into this is, I'm sharing this there. MoMo's their initial product. You can use one user with that, so you can use it for talks and that kind of stuff. So somebody turned me onto this because I was advertising for a different meeting. But okay, so look, that's what I fed in, and you feed in like 10 pictures of yourself, right? So I haven't had hair since since I was a teenager, and it refuses to make me bald. So look at that. Look at how cute that penguin is. It's great. Anyway, long story short, pros, it makes you look a lot better than you really look in real life. The cons is it discriminates against you if you're bald. And I felt so bad about myself since I've looked at that I'm going to fly to Turkey to get hair implants before the next TCOS meeting. So anyway, moving on to what I really wanted to talk about was single row rotator cuff repair using an orthobiologic interpositional demineralized bone fiber implant. I don't have any financial disclosures. So the basis of this is that this technique has been already published looking at it from a double row. This is discussion looking at a single row. I preferentially use single row. I think single row rotator cuff repair works well. While there are numerous studies that show that there's results that are better biomechanically with double row repair, clinically there's really not that much of a difference. There are also biomechanical studies looking at this, not looking at it from like whatever you want to call a speed bridge type of fashion. But if you take a triple loaded anchor and you tie multiple knots and multiple suture passes through the rotator cuff, that you can get a biomechanically equivalent or sometimes superior outcome. Again, clinical outcomes are solid. The thing that really matters is to get that tendon to heal to the bone. So the question is, how are you going to do that? And if you can create a repair construct that has less tension, it's ideal. This is talking about a demineralized bone fiber implant, so DBM, using it approaches this from an orthobiologic standpoint from a little bit different perspective. Most of the time we're talking about using different kinds of membranes or different kinds of patches for the rotator cuff. This actually looks at a way to increase enthesis healing, so trying to get the rotator cuff to heal onto the bone itself. Again, most of your failures occur at the bone tendon interface. There are studies that show that if you just take DBM by itself and sprinkle it in there underneath your repair, that actually helps increase healing. So those are done in animal models already. This particular implant, it was presented at AOSSM last year, won an award because it kind of attaches things at a different way. This is basically the construct that I use. So again, in that you can see the tendon, oh, I don't have a pointer, but you can see the tendon coming down, and the idea is to park it in a trough that's made right there. I think a lot of people met Dr. Uribe yesterday. That's his method, is to make a trough. So you basically decorticate the bone so that you can actually get the tendon to kind of find a new home. So this is the technique. Again, this is coming from a lateral portal. I'm trying to create the trough there. I don't really like the angle, so I'm going to switch. You're going to see me clean, clean, clean. So now I'm coming from the anterior portal. I'm just kind of touching up the bone. Yeah, I make a deep trough. So cleaning it up so you guys can see it better. Also, so I can get my anchors in. We'll skip a lot of the tying, but I put a couple margin convergent stitches in the back, and then I'm putting in additional sutures, trying to see if it'll come over freely over to the trough, which it does. Again, just cleaning up so we can see. I don't use cannulas. I prefer not to. Sometimes it leads to this, but usually it's good visualization. This is putting in the implant. You can see, look at all the kind of marrow elements that are escaping when you put that in. So it actually, if you look at a scoiro technique where they microfracture the outside of it and try to get healing potential, this is similar to that. So this is getting deep into the thing, and then this is the DBM implant. So you take that and you just tap it into the bone. You kind of twist, twist, twist it out. It's actually pretty long, so it does a good job of wicking your healing elements from inside the bone. So you'll see the length of that core as I take it out. It's a lot longer than you think it is. See, look at that. It just keeps coming. Yeah. Keeps going. It's actually pretty easy to put in. So we're going to take it over. I tie different numbers, so I prefer not tying knots. So depending on how mobile the cuff tissue is and how big the tear is, sometimes I'll put 2 suture passes in and then use an anchor that will accommodate that, or this is one that takes 1. It allows you to tension each individual limb. That's why I like this particular anchor. And so it comes out. Just kind of clean it up. And then go to the next. So this is what it looks like from picture. And then looking from the lateral portal, this is your final product. Again, I like putting in margin convergence because sometimes that acts as kind of like a rip stop for your repair. And that's about it. Thank you again from Baptist Health International. Hope you guys enjoyed the talk. And yeah.
I didn't know you could fight like that, Suman. Next up, we have Dr. James Ross talking about joint preservation, restoration rather than replacement.
All right, thank you very much for having me to talk about this topic that is very dear to me and exciting nowadays. So joint replacements, you guys have heard about this already today. Very great option for patients that need it. How could we perhaps avoid them? So for the joint preservation, we're going to talk specifically about the knee. So most patients that have knee pain, they present to the office, they have osteoarthritis, and an excellent solution is a knee replacement. But what do you do for this patient who's young, active, has significant knee pain, and has preserved joint spaces? So I think before we talk about some of the different options out there, I think it's very important to talk about knee anatomy for some of the people that are either Listening in, we'll go through some of the anatomy. So the knees hinge portion of the joint is mainly between the femoral condyles and the tibial plateau, and that has articular cartilage, is what I like to tell patients, is the white shiny stuff you see on the ends of chicken bones, and that's responsible for cushion, padding, as well as having friction-free motion of the knee. And just as equally important are the menisci for joint preservation, which is in between. So this is a 30-year-old patient that presented to my office with significant knee pain. And as you can see on their x-ray, they have preserved joint spaces. And what's within that joint is the articular cartilage of the femur depicted in blue, the articular cartilage of the tibial plateau depicted in green, as well as the meniscus depicted in pink. But when we get an MRI, this is what you see. So this patient has medial joint line pain, and on that sagittal MRI where the black arrows are, you can see that the cartilage on top of the subchondral bone is gone. So what does that look like? So at the time of arthroscopy for this patient, with the knee in extension, the photo on the left shows beautiful looking articular cartilage, but once you flex the knee and find the area of the defect, you can see the subchondral bone. And what do you do for this patient? I think in the past, chondroplasty, microfracture were kind of the treatment options that we had, but those are usually temporary and they don't have great durability. Microfracture ends up with a scar type of cartilage that will likely break down with time. But as technology and techniques have developed over time, we have newer techniques that can be used in order to replace the articular cartilage with better articular cartilage, and that's what we'll go through today. So this is that patient, and the option that I chose for this patient was an osteochondral allograft. So what's done in this situation is this patient's MRI is sent off to a graft company, which I like to use as Joint Restorations Foundation, and they make measurements off of the MRI, and when they get a donor that has a knee that's the size that matches your patient, then you get the offer in the email and have time to accept it, and usually time from harvesting to time of implantation is ideal within a couple of weeks. So this donor was a male who's 20 years old, and if you look in the charts, you can see the condylar width of our patient in upper right was 2.7 millimeters, whereas if this donor was 2.6. So an excellent candidate for this graft option for my patient. So at the time of surgery, what we do is we core out an appropriate sized circular plug or donor site for this patient, and then we go to the donor condyle, harvest a plug, and then reimplant it. And you get bone-to-bone healing, and then the chondrocytes or the cartilage cells that are within that articular cartilage are alive and are meant to continue to remain alive for this patient in the long run. But as equally as important as what you do to the cartilage is trying to figure out if there's any underlying factors that predispose them to getting that. So alignment. That's one big thing that we're always looking at in these patients. And if you take a standing alignment x-ray for this patient, you can see that their weight-bearing axis from the center of the hip to the center of the ankle travels through the medial compartment of the knee, which is where this patient's defect is. And in order to have a very good successful outcome, I think that it's equally as important in order to offload that compartment by performing an osteotomy. So what we do is we contemplate the degree of correction and do that procedure and reliably get their alignment back down to the center of the knee. So how do these patients do? This is the best study that I think we have out there. It's a systematic review of 19 studies compiling over 1,000 patients. And these are the numbers that I quote to my patients when we talk about these procedures, is that at 10-year survival for an osteochondral allograft is about 80%, and 20 years is almost 70%. That's pretty successful, especially if you have a young 20, 30-year-old patient. Hoping to get them 20 years could maybe get them till they get a knee replacement in their 50s or 60s, and along the way having a much more pain-free and active lifestyle. But what about not going so far as replacing only the cartilage and the bone? Is there anything that we can do to replace the cartilage alone? And that's where we delve into the restoration, and specifically autologous chondrocyte implantation. So what is ACI? So ACI uses cultured cartilage cells or chondrocytes from your patient to repair this full thickness cartilage defect in the knee. So this was actually performed first in Europe in 1994 and eventually made its way to the US, but it was a very tedious procedure. It worked well, but surgeons didn't like to do it because it was very tedious. Oftentimes you had to harvest a periosteum of the medial tibia, sew it in over the defect, get your cartilage solution, which was liquid, make sure it was completely sealed off, and then inject it under the flap. And it worked well, but it was very tedious, so it really wasn't much in favor. But then the second generation, which is the MACI, or matrix autologous chondrocyte implantation, was developed, and that is the cells, rather than coming in a liquid solution, are actually embedded onto a collagen membrane and a collagen patch that you can glue and sew in. And that started being performed in Europe in 2003 with very good success. And then once they performed their studies, was approved by the FDA in 2016, and we were able to utilize that here. So there's three key steps to MACI. The first being diagnostic arthroscopy, where we assess the defect, make sure that they're a candidate, they don't have bipolar cartilage lesions, and see if they need any other sort of meniscus transplantation or anything like that. And then at the time of that procedure, we perform the cartilage biopsy. Second stage, or the second step, is that that cartilage is sent off to a lab, Vericel, which is in Boston. They isolate the chondrocytes, they culture them, they propagate them, and then eventually seed them onto a membrane. And then the third step is the second stage surgery, which is predominantly open, but now they've developed an arthroscopic technique, and that's implantation of this cartilage membrane. So during that first procedure, as I mentioned, we really scrutinize the defect, how big it's going to be, because that will determine how many membranes are needed, and whether or not they may have another defect in perhaps the trochlea or the patella, and then figure out the size and make sure that there's no bony involvement. And then we harvest the biopsy. So this is how I like to harvest my biopsy. I used a ring curette on the intercondylar notch, which is an area that's not really articular and can be donated. And we harvest these biopsies, which are about the size of two Tic Tacs. So I try to keep a hinge attached so it's not floating around all over the place, and then I go on a scavenger hunt. And then once those biopsies are taken, we pass them sterilely off the back table onto this cartilage solution. And once we get the patient's information, their defect size, we send it off to the lab. So here's the science. So this membrane is pretty awesome. So it's got two sides. It's got a shiny side, which is a smooth surface, and then it has the rough surface. So the smooth surface is the surface that's eventually going to face the joint, and the rough surface is going to be the surface that actually faces the bone. And that rough surface has multiple interweaving collagen fibers, and that's what aids in those chondrocytes or those cartilage cell attachments. All of the chondrocytes, which are populated, have these cytoplasmic extensions, and it adheres to that rough surface, so that at the time of surgery, that's what gets implanted. So we prepare the defect, we remove all of the diseased cartilage, we get very good shoulders of normal articular cartilage, take off the calcified layer of cartilage, and then I like to use a piece of foil from a suture wrapper in order to template what the size of my implant's going to look like, and then I use that foil, lay it over the membrane, and then cut it out so that I have the perfect size. And then we use a fibrin glue at the base, and then once that fibrin glue is there, we simply place the membrane rough side down within the defect, hold some digital pressure from some time, and then some people, depending on the size of the defects, occasionally I'll like to throw in some 5-0 vicryl sutures. So this is a specific case from one of my patients that had a pretty large central patellar defect. You can see after I fully prepared it in the upper left with that foil template, and then on my glove, if you can kind of see the purplish hue, that's actually the implant itself, and then after the implant is glued into place. So what happens? So within 48 hours, these cells will actually migrate off of the collagen membrane and adhere to the subchondral bone. And they start to propagate, and they also start to create the matrix proteins and all the collagen that's needed in order to synthesize more articular cartilage and fill in that defect. And it relies a lot on the motion and continuous passive motion machines in order for you to create that, because that's what prevents the chondrocytes from making extra matrix and overgrowing. So actually, therapy is extremely important in these types of procedures. So how do these patients do? So this was the design, this was the trial that actually allowed the FDA to approve this use for the United States. And this was a randomized controlled trial within Europe of 16 sites, and they randomized 144 patients to either microfracture or MACI. And they followed them for 2 years, looking at their clinical outcome scores MRIs, second look arthroscopy, as well as some patients the biopsy. And what they found is that 2 years, the pain and function subscales of KOOS significantly improved in both groups, but significantly more in the MACI group as opposed to the microfracture. And then they carried this out to 5 years and showed that the MACI group maintains their pain and function scores, and microfracture starts to tail off. So the clinical success of this, though, is very important on creating a favorable environment for the MACI implant, and that's not only stability, but then also alignment, which we talked about. This was a patient with a very large medial femoral condyle defect. He's 35 years old, and you can see that's the second picture is the MACI implant in place. So big defect, and his alignment shows that there's significant genu varum and the weight-bearing access right through the center of that compartment, and that's his osteotomy to offload the compartment. He's 7 years out. I just saw him 2 months ago because now he has the same thing on the other side at his left knee, he says, is absolutely perfect. And then finally, the third critical component is meniscus integrity. So that's where the diagnostic arthroscopy is very important, because if you see meniscus insufficiency, that's something that you want to plan to do at the same time, or address at the same time as your MACI implant. This is a 35-year-old patient, had a prior lateral or prior meniscectomy with loss of the posterior horn. So what do we do for that? This is a meniscus allograft, so similar to an osteochondral allograft, we can send off the MRI and obtain meniscus allograft for transplantation. The beauty of the meniscus is it doesn't need to be as quickly implanted because there's not living cells like the cartilage. So you can have a patient MRI and a selection for a meniscus that can be held for even up to a year. So during arthroscopy, there's several ways to do this. My preferred technique is to leave the root attachments of the meniscus to the bone. There are people doing just soft tissue onlays, but I still think bone-to-bone healing is the best. So I create a bony socket both in the posterior aspect, root insertion, as well as the anterior root insertions, place shuttling sutures, and then these shuttling sutures are utilized in order to deliver the allograft into the medial compartment. So it can get a little tight, so sometimes fenestrating the MCL can be very helpful. And you can sneak that posterior root plug back into its place and eventually dunk it down into the socket. And then once that's in position, tie it over an endo button, a knotless anchor over the tibia, and then do the same thing to the anterior root, which you see right here. Once both of these roots are secured, then essentially you have a large bucket handle meniscus to repair. And you can utilize inside out, all inside techniques for suturing. I like to use still standardized inside out. I think it's the smallest puncture holes, the less damage to the meniscus. I usually try to place about 10 sutures, 10 to 12 sutures, both on the total, both on the femoral and the tibial surface. And then as you get to the front, you can either sew it in through your arthrotomy or use a suture shuttling passing device in order to anchor in the anterior aspect of the meniscus to your capsule, because that's where all your blood supply is going to be. And then once that's sutured in, this is your final product. So you can see now he's got healthy looking articular cartilage, and now he's got a meniscus to hopefully continue to preserve his joint for the long run. So in conclusion, joint preservation surgery in the appropriately indicated patient, and that's very important, has very reliable outcomes for pain and function. And the rapid evolution of these techniques and treatments must be followed by well-performed investigations, which fortunately we have ongoing at this time. Thank you.
Those were both excellent talks. We'll open up to questions.
For the patient who ended up with bilateral knee pain, has anyone looked at potentially, if you're already treating one side with MACI, doing the corrective osteotomy on the other side as well, rather than waiting till them to be symptomatic 2 or 3 years later?
It's a great option, or a great idea, a great option. The problem is osteotomies, as you're well aware, hurt. And if a patient has a pain-free joint, the likelihood of getting them to buy into an osteotomy is going to be challenging. But I would argue that that's the whole reason he developed the cartilage problems that he had. So I think an osteotomy would be great and would probably prevent it, but getting someone to buy into it or even insurance to pay for it would be difficult.
Dr. Ross, the bucket handle repair you just showed, how long is the person after they do that? How active can they be after? And how long does it take? Can they do sports or et cetera?
Great question. So my rehab protocol is to have those patients partial weight bearing for 6 weeks more to protect the root insertion, with an ultimate return to their level of function at about 5 to 6 months. There's actually more data on the osteochondral allografts, the cartilage plugs for return to sports, and especially at high level. I think that once you get to the point where you need a meniscus transplant, you're counseling the patient that, you know, we just did a big procedure to try to preserve your joint. It's probably not best for you to be involved in high level activities. However, I've had plenty of patients that, you know, a police officer who plays pickup basketball, a dentist in town who plays ice hockey, like, they go back to playing sports.
Dr. Ross, if and when you come across bone bruises in your practice in some of those patients, do you have an algorithm for assessing its contribution to pain and how it itself is managed in those circumstances?
Awesome question. Bone bruises hurt like crazy, as you guys know. And I think that now that imaging is getting better, we're picking up reasons why they happen. So the whole spontaneous osteonecrosis of the medial femoral condyle, I don't think that's an avascular necrosis. That's like a root tear of the meniscus. That's like a radial tear of the meniscus that we didn't really appreciate before. So a lot of these patients that have the bone bruises, I try to figure out why. So if they have a radial tear of the meniscus and it's a young patient with an acute injury, I'm arguing hard for them to try to do surgery. But if it's a 55, 60-year-old patient with a root tear, they're overweight and they've got bone bruise, you know, for them I'm talking more about offloading braces, injections to try to get them through. But I think that if you do things like unloader braces and modify their activities and you get their bone bruise to heal, I think their pain goes substantially down.
Do you ever do subchondroplasty for those or no?
I'll do some chondroplasty if I'm going to surgery for it. But if an isolated bone bruise, I try to offload them first before doing that, but if need be, yes.
So essentially, you are awaiting its resolution before going on to the cartilage lesion.
It depends. So it depends on what the cartilage looks like on top of it. So some of those patients can have bone bruises with normal articular cartilage that hasn't broken down yet because the bone is starting to sense increased pressure. And again, something happened. You know, something happened to that patient, whether it's a root tear or radial tear. If that cartilage is intact, that's a dramatic change in the nature that the bone is seeing and feeling that caused that bone bruise to happen. On the contrary, when you have a full thickness cartilage defect that's there with a normal meniscus and bone bruising, that's a different animal. And then that's something that I would be more pushing towards, like an osteochondral allograft, replacing both the cartilage and that unhealthy bone, because the subchondral bone is usually pretty involved too.
Good talks. Both talks were good. Dr. Moss, in my setting, I find root tears to be an underdiagnosed lesion. And I typically find them most of the time at the time of arthroscopy rather than as a diagnosed lesion from the radiologist. What is your view about the avulsed meniscus? Do you think that we should look for root injuries for those observed meniscal pathologies?
Absolutely, and I think sometimes the imaging is, you know, if you have a 3 Tesla MRI with thin slices, you can usually see it. But some of these patients that come in with MRIs that are already performed, it's hard to make it out. You can get an assumption, and sometimes looking at the coronal MRI and seeing if there's any meniscus extrusion. Yeah. If I see that, then I really try to scrutinize the root. And if I think there's a root tear there, I'll either repeat the MRI or tell them that there's a good chance that that's what we're going to do at the time of surgery. So a patient with healthy cartilage with a root tear that's young and active, I think a root repair is a very good option. It's a difficult, challenging recovery, but I think our surgical techniques have evolved to try to get it to heal better. And there was a recent study that was done at Mayo Clinic that they actually use a centralization suture. So in addition to the root sutures tacking it down, at the mid-body of the meniscus, if you put a suture anchor, usually a knotless suture anchor into the tibia, and incorporate that through the meniscus capsule junction at the mid-body and bring it in, the successes of your root repair are even greater.
Yeah, I was going to say Aaron Critch's work at Mayo, he's done a lot of work on that, and I think if we get it to those earlier, we help prevent people to get into, later arthroplasty situations.
Great.
Question: what's your rehab protocol like for the MACI for the patella, and with such a large defect, how does it compare to just resurfacing the patella?
So it's much longer. So I tell patients that full incorporation of the MACI implant is about a year to a year and a half. So they all get CPMs for 6 weeks. Patellas I usually let weight bear earlier than femoral condyles. So I'll let them weight bear in extension usually at three weeks. But loading with like knee extension and squats, I mean, you're talking about 2 to 3 months after surgery before even doing just body weight. So it's a long, long process, and you just got to make sure that the patient is bought in. And often that's a reason why we don't do it on young athletes who have seasons to go back to, is because they can't afford missing 1 to 2 seasons, as opposed to an osteochondral allograft. Return to play could be 7 to 9 months.
For your, Dr. Ross, allograft replacement, is it more, well, what's a typical patient in terms of an indication, and what patient is it contraindicated in? And I guess a general question is it more to try to replace function, or it's a pain control? Ultimately, you're trying to delay the need for a joint replacement, but is it more for the patient with functional issue in terms of stability, or it's pain?
Which replacement? I missed the beginning.
The allograft replacement of the meniscus.
The meniscus allograft.
Yes.
Okay. Yeah, so that's more for the patient who has pain with meniscus insufficiency. And they're usually patients that have already had a knee arthroscopy. So someone that's 30 years old, normal-looking cartilage, you get their MRI, and you can hardly see a posterior horn anymore. That's the ideal patient for it. And the idea is to do it to delay the need for a knee replacement. So contraindication for me would be bipolar changes or significant chondral loss on the femoral condyle. Because I think if you have a focal cartilage defect on the mediofemoral condyle with meniscus insufficiency, and they're young and active, I still think that they're a good candidate to do both the meniscus transplant and some sort of cartilage procedure. And there's very good data to support that.
For anyone, really, this is probably a theoretical question. We all grew up on concept of coronal alignment, or certainly importance of restoring that. Is there any concept of a sagittal alignment important in the knee?
Absolutely.
That's a great question.
That is the hottest topic right now in ACL reconstruction, is tibial slope. I mean, this is huge. So, and I actually did 2 corrective sagittal alignments in the last 2 months for people that are on their 4th ACL. So, tibial slope greater than 12 degrees right now is kind of what people are recommending, not in the primary setting, but in like a revision ACL reconstruction setting in order to do a slope-reducing osteotomy. So it's not uncommon. For Tuesday, so Tuesday I did a case. She's had 2 failed ACLs, 1 allograft, 1 autograft. Tunnels were in pretty good position. She has medial meniscus insufficiency, but when you do her exam, I mean, it's like the Lockman that the medical student can do. Like, you can see it from across the room, and you could lock her on a pivot shift test. So those are the patients that, you worry about just doing another ACL. So this concept of sagittal alignment and tibial slope is huge right now, and there's actually some new osteotomy companies that have come out with custom osteotomy guides to do these types of procedures.
You use that, right? The new
BodyCAD, yeah, we just got it in. So, and it's awesome. It's unbelievable.
How do you go about treating the relatively young patient with a neglected ACL and possibly some early joint pain?
So depends on their activity level. I mean, if they're running around trying to do things, or even the knees giving out on them during their normal activities of daily living, I think an ACL reconstruction is important. The chronic ACL, where they start to stretch out the extracapsular structures, I think a graft alone, especially if their tibial slope is a little elevated, is probably not enough. And I think that that's where these procedures, like a lateral extra-articular tenodesis, can be very helpful. So if I have someone who comes to me and they say, yeah, I tore my ACL 5 years ago and it's just finally bothering me enough to do a reconstruction, and they have a very loose Lockman's and a very high-grade 3+ pivot shift, not only are they getting, in my hands, a patellar tendon autograft ACL, but they're getting a lateral extra-articular tenodesis with iliotibial band, just as backup biology to help keep the knee stable during that ligamentization process of the ACL. Because I think if you ignore all of that extra-articular laxity, I think as the graft is healing in, it just stretches out, and then eventually it's going to give.
Dr. Ribas, you had a question?
Thank you, Dr. Cardoso. With your permission, we have a question from Dr. Randolph Carrington from Barbados that says, Dr. Ross, do you allow partial weight bearing after meniscus graft? You do allow partial weight bearing after meniscus graft. Do you immobilize the knee at all?
Only for the first 5 to 7 days until I see them at my first post-op. They're locked in extension. And then for partial weight bearing, yes. I think that complete non-weight bearing, I think, just ends up in more atrophy. So I do like to use like 20 pounds partial weight bearing the foot of their, or the weight of their leg. I think that that's safe.
I had a question for Dr. Papp. So using the DBM fiber implant, do you feel like it's changed your clinical practice? Do you get people back to moving faster? Are you less cautious? Have you seen a difference? And has there been any complications? Do they ever come out? Or is there a fracture in the process of putting them in?
So I'll work backwards. I haven't seen a complication yet. It's pretty easy to put in. In terms of my rehab protocol, I'm pretty aggressive with my rehab as it is. The initial studies on this thing show that it increases, and this wasn't done in a person, it was done in sheep, but the pullout is better faster. So theoretically, you can let them do more faster. The idea is, again, to get that, promote the tendon to bone healing faster. Has it necessarily changed my practice? No. I think, again, I had this talk with Mark Gettleman, but it was like, for the vast majority of the cuffs that we fix, you don't really have to worry about them. It's that, 10 to 20% that, the Rohe score is high and you want to do whatever you can to make it heal. And this is, I think, another tool in your toolbox that you can use.
Cool. So great. Do you have a size rotator cuff tear, A to P, that you're thinking that this is for?
Yeah, I mean, this is more your massive cuff tear, your tear. I mean, again, you can use it in older patients because it potentially helps with the healing. Revisions as well. Yeah, I just had a big revision on, I forget if it was Tuesday or Wednesday, but I made a joke with my staff about using everything, and that was one of the things I used.
Great. Sir?
When it comes to cuff tears, the older patient with a thin cuff has a higher risk of re-tear, even though good surgery was done.
Yeah.
And so augmentation with a similar type scaffold has become quite popular, like Regeniten, for example. What is your view about using a bioscaffold like Regeniten to thicken the cuff as an end result, rather than the bioscaffold that you use, which was like a bone plug,
So
to transfer material to the cuff?
I think your question's excellent. I think there are different ways to attack that problem. I think using those kind of membranes is great. You know, again, if we're talking about certain products, Regeniten has a good amount of data that shows that it works. There are papers that show that it can have an inflammatory effect on patients, which I think is actually positive. I think it shows that patient that there's actually healing there, but it can be frustrating for the patient at like the 2-month, 3-month mark because they get kind of inflamed, they get kind of angry. There are other products out there that are similar to that. But it is something that I use quite commonly in my practice. And before this thing, I will use them together. Like if you have really bad cuff tissue and I can put that in there, I mean, why not give the patient the best chance to heal?
All right, I think we're wrapping that session up. Thanks, everybody.
Thank you.
Thank you.